I am super excited today to introduce to all of you Dr. Shaibya Saldanham. Welcome, and it's lovely to have you here. I have known Dr. Shaibya for, I think, at least 13 years or 14 years, and I've heard so much about her before. We met in person. She is an obstetrician and gynecologist of over 30 years of experience. And from what I've seen, heard, and experienced for myself, I know that she's a very, very conscious provider. She actually sits across from all her patients and listens to everything that they have to say. She has extensive experience in sexuality counseling, and she also has a wide experience working in different care providing situations like hospitals and rural hospitals, urban hospitals, and primary healthcare centers. Right now, she is in a very remote area in Meghalaya on a 3-year contract, serving the underserved and improving birth outcomes there. Today, she will be talking about a very, very important topic, and that's obstetric violence and what we all think and feel about it. And we are looking forward to your presentation, and welcome again.
Thank you. Thank you so much. Thank you for inviting me. I was so delighted actually when I first got a call saying you'd like to talk to me and Augustine and with the Midwifery Collective. I'm slowly moving away from the whole idea of doctors controlling labor to doulas or midwives controlling labor. And so a lot of my conversation will be about that. I'd like to start with obstetrical violence in terms of what do we mean by it. And I'd like to start with one of my senior professors was talking about, she had one daughter, and she and her husband had a car accident, and both of them, narrowly, missed dying, and they survived. And she was very shaken. She had, her daughter was 15 or 16. And she said, when she was recovering in the hospital, we found out about it, and she was brought to the hospital, and we went to see how she was doing and her husband was doing. And she said, my daughter turned around and told me, why were you driving at that late at night? Why didn't you think of me? You only had me. You're the only people I have. I'm your only child. You can't leave me like that. And she said that I thought back to the time when she was born. So she and her husband studied in India, and then they went abroad, both of them. Now, their marriage had been intercaste, intercommunity, interstate. So there was some amount of resistance from the families, particularly her family. So they went abroad and she became pregnant there, and she had a baby abroad in a Western country, a developed country. And she was so traumatized by it because she was alone in the labor room. Her husband was a doctor too, so was she. She was an obstetrician. But he had to wait outside. She had nobody with her in labor. She delivered. It was painful. She was anxious. She was worried, and there was nobody to hold her hand. And then the baby delivered normally, and then she had to breastfeed. She didn't know how to breastfeed. The baby was crying. She was an obstetrician, but somehow when it's your own body and your own baby, you just tend to panic. And she missed any elder person around to take care of her. And I think for me, that was a lasting memory. She said, I could not even have thought. I wanted 2 kids. Maybe my husband would have liked 2 kids too. But it was such a horrible experience that I never wanted to have another baby ever again. I never wanted to go into a labor room. And some of the ways she would talk to us would be like, when you're doing a PV examination, is the speculum warm? Are your gloves comfortable? Have you taken a lubricant? Have you tried? Are you pushing your finger in? Are you telling the patient, I'm going to do a PV? Are you telling the patient, I'm withdrawing my fingers? Small little things, which for her had made such a huge difference. So I think, she was in a first world country. They were both doctors, and one presumes that their experience should have been safe in terms of maternal and child care. But it wasn't safe in terms of physical, emotional spaces. And that is where we look at obstetrical violence. To start further down, so if you look at the fact that the traditional birth attendants that we always had, nobody shouted at you and yelled at you. So that was the way that women were protected and taken care of. Medically, yes, there was higher risk, and there is still high risk of uh, maternal morbidity and mortality in home births without adequate medical care. But the comfort they felt was what was important. How do we define obstetrical violence? WHO defines it as violence faced by women during childbirth, which means this could be physical abuse, this could be verbal abuse causing severe humiliation or a loss of dignity. And those of you who have ever worked in a government hospital or worked in a small town or attended with somebody, your sister, a cousin, somebody, you would see how much there is harshness against women. Neglectful behavior, just put a woman in labor and leave her there and everybody's running around because she's safe, baby's safe, so we don't really have to worry about her. And that sort of neglect. Unethical procedures, and this can be whether it's an episiotomy, which is not right, or push to a cesarean without giving information, breach of privacy, the fact that you have a labor room with 10 beds, there are no curtains in between, and the presumption that if a woman is in labor and she's in so much pain that she doesn't care, that her legs are bare, that her legs are spread out, and that it's open to everybody around her, even if they're all women, then these are what WHO defines it, but there are certain feminist scholars who also look at it as a gender-based violence because women undergo labor. If men underwent labor, would we have the same rigidity in taking care of them is the question. And here I would also like to add persons with a uterus who are also disrespected. So there may be people who are gender fluid, who do not identify as a woman, but they are people with a uterus who may have a labor, who may go into labor, who would like to have a baby, and disrespect from them is also something that we need to look at. Now, when did this concept of obstetrical violence arise? It actually happened in the early 1980s in Spain and Latin America. And this was against the over-medicalization of labor, against the dehumanizing experience women faced in labor. And what do we mean by that? First of all, the whole idea that, women delivering at home are very dangerous. They'll die. They don't have blood. They have PPH. They have eclamptic fits. They may die over there. Or the whole thing of putting pressure on a mother's tummy to make her deliver, which were some of the traditional methods when a woman was not able to deliver. So as a sort of pendulum shift, it was into hospital. And then the whole process of labor was like this pathology, even pregnancy, as so many of you know, when a woman is pregnant, don't travel, don't move this, don't eat papaya. So many absolutely absurd things are told. And doctors say this, terrify the woman about travel, about movement, about doing her regular work. And yet, on the other hand, none of us ever say, in the last 2 months, take it easy. Don't do the hard, heavy work that you do. Be relaxed. The baby has to grow. The last 2-3 months is when the baby puts on weight. We want you to do your regular work, but don't get physically strained. Try to take a little more care of yourself, sleep more, take care of yourself more. So the over-medicalization, this constant need to do hundreds and hundreds of blood tests because it's now become something which is like doctors, it's called CYA, right? Cover your ass. So it's a question of doing every single test. So there's no way the baby can ever, have any problems, which can then rebound on the doctor and the doctor may be sued. And also the fact that they worry about doing, sometimes I've seen patients going for a simple ultrasound. And in the ultrasound, there's one small echogenic calcific focus in the heart, or one small little thing of the head being a little larger, a little smaller. And you can see the parents, and you can see that the heads are large or the heads are small. So you realize it's a genetic thing in the family. But the ultrasonologist gives them very scary pictures of a brain damage, and you need to go for amniocentesis and this, and we can't guarantee you the child's okay. What on earth is the use of terrifying people like that? It creates so much fear. So this over-medicalization of labor and then the dehumanizing experience when you bring women into the hospital and then treat them like goats and dogs and things like that. And literally, I'm not joking when I say that. this dehumanizing experience where you keep everybody outside was the reason why in Spain and Latin America they reacted to this. And they did it in a way that they called it, if you if a woman faced obstetric violence, then it could be a criminal action against the doctor could be taken or the nurses. And this happened in Venezuela in 2007, in Argentina in 2009, and in Mexico in 2014. So this was the development of the concept that obstetrical violence is very much there. We've always seen it happening, especially in the health system, but we never named it. If you look at obstetric violence, there are so many facets of it. It's not just obstetric violence. So I'm going to ask, is it a human rights violation? And what would we consider a human rights violation? Refusal, even when we say child rights violation, the right to participate in your own treatment, the right to be heard. So when we refuse to listen to the woman saying, I'm really very scared, doctor, about labor. Don't be silly, it's fine. It's a very normal process. No, my sister had a very terrible experience. No, it's fine. It's okay. You'll be fine. Don't worry. We refuse to listen, to sit and ask her, why are you scared? What is it that worries you? Refusal to give her an autonomy over her own body. And there were two examples I'd give you where this woman said, I'm scared of labor. And she'd had scary stories of her sister and her cousins, all talking of long labor, forceps, abdominal fundal pressure put, a terrifying experience. Sutures put, episiotomy put without anesthesia. So when I spoke to her, I said, I'm not going to force you to go into labor. Let's wait and see. If you find, so we talked about breathing exercises, we talked about relaxation of the pelvis, we spoke about having a husband in the labor room with her at all times. We talked about back massages, hot water showers, and also said that I'm not going to force you. If you find the pain is too much, I will do a cesarean, but let's just see how it works. So she came, she called me at about 11:30 or 12 at night saying my bag of waters has burst, but I'm just getting a little achiness in my back, nothing much. She reached the hospital by about 1 o'clock in the morning. I saw her and examined her. She was about 4 centimeters dilated. I said, that's great. Are you getting any pain? She said, no, just a little bit of, tightness every few minutes, 20 minutes, 20 minutes. I said, there's time. So, doctor, will you do a cesarean? I said, definitely, if the pain is too much, I will do a cesarean. Shall we just wait a while? You walk around, still time. And then suddenly at about 5:30, she was like, I'm feeling like I want to push. It's getting very painful, doctor. I said, let's shift you into the labor room. And she delivered at 5:30. Within 15 minutes, and she said, it's over. I said, well, yes, it seems so. She said, oh, but it wasn't painful. I said, yes, some people are lucky and they don't have pain, and you were comfortable, and the baby was really cooperative and happy to come out, and it was fine. And so for her, she felt heard, she was relaxed, I feel, and her husband was there all the time. Her mother was giving her back massages. She was walking around, emptying her bladder. So this, if I just said, no, we can't do a cesarean, don't be silly. You girls, women nowadays are too fussy. You don't, you're just scared of pain. You're not physically active. Look at your grandmothers and mothers. They all had babies normally. So this is, I would consider a human rights violation. Refusing analgesia. How many of you have heard women crying, saying, please give me some painkiller, it's painful. And just saying, no, it's okay. It'll be a little while. Don't worry. It'll be a little while. But not really actually helping her. There are so many simple methods to reduce the pain. Refusing a birth companion, I would consider it human rights violation. It's like isolating a person. It's actually putting them in an isolatory chamber. A person, because we have found that having a birth companion reduces pain or the need for analgesia by almost 50%. The chances of obstetric complications or fetal distress reduced by almost 30 to 35%. The chances of postpartum hemorrhage reduce. And the birth companion is there to take the lady to the bathroom, to help her pass urine, to give her sips of water, to give her juice, to give her little bits of food, making her feel safe and protected. Imagine taking that away from her and saying, no, keeping her in solitary confinement. The lack of privacy. Imagine a person just being bare. So many women have said, I was uncomfortable. Ward boys coming in, male doctors, male nurses walking around. and this feeling bare with your legs separated, your whole perineum open to everybody. What does that mean? Anybody coming in, putting on gloves and doing a PV examination without explaining what they're doing, why they're doing it, not even giving a sheet to cover you, and physical or verbal abuse while in labor. These are all what I would consider human rights violations. So obstetric violence is a human rights violation. And then, as mentioned earlier, unrequired episiotomies or giving it without anesthesia. I've even heard of suturing. Women have said it was so painful. And I said, why? So you give the local anesthesia and immediately put the stitch without waiting the 5 minutes for the anesthesia to start functioning. Obstetric violence is a structural violence. What do we mean by structural violence? It's in the social arrangement that put an individual or put a community in harm's way is what we call structural violence. And the basis of this lies in the way our public health systems are created. Somewhere along the way, while public health systems in certain countries, in UK, Cuba, Costa Rica, work very well, in some European countries, the public health systems work because they realize that this is the government owes the people that. And somehow in our country, in India, we seem to believe that the public health systems are meant to be doing charity. And that is not true. Sometimes when I talk to doctors in the public health system and I say, do you give free treatment to patients? And they go, yes, it's all free for them. And I said, no, it's not. All the people who come to your health systems, the laborers, the agricultural workers, the sanitation workers, the domestic workers, the people with small, shops, roadside stalls, they are the ones who are coming to your public health systems, right? Because they can't afford private health care. But if those people all stopped working today, put down their instruments, and did not go to work, our country's economy would shut down. We wouldn't have an economy. That 70% of people who are actually doing the mining. So I told the doctors that car you're driving is because the people who come to your hospital are digging the mines out. We heard about the rat hole miners who saved all those 41 people when the army and the navy and the Australia and the Air Force, everybody who came there couldn't help them out. They are the people who run this country's economy. And their labor that they're giving, because it is not quantified, is presumed to be worthless. But this is what the government owes them, because the government stands the money of the taxes. It comes from the taxes they pay. And now if you look at GST and things like that, there are what we call indirect taxes. They may not pay income tax because they don't earn enough to pay income tax. But for every packet of salt, packet of oil, the sugar they use, they are paying a tax on every single thing. They pay road tax to carry the vegetables to the market to sell. If they all stopped working, our country would go down. None of us, fancy doctors, counselors, doulas, any of us do any money, give any money towards the government. Very little. Very, very little. It's minuscule. And so the public health systems are not doing charity. They're giving back to the people a small, tiny amount of what the people are giving to them. All the wheat that we sell, all the meat that we sell, all those fancy pineapples that we're selling in Dubai are all their work. So the public health systems, unfortunately, have insufficient funding. As you know, as a percent of our GDP, India pays the least amount towards healthcare. We have a very poor provider, poor patient ratio. So our nurses, and you can't then blame them for being impatient or angry or disrespectful because they're so tired, they're so overworked. I know that in my medical hospital, in the college where I studied, sometimes I had slept maybe 10 hours in 72 in little snippets of 2 hours, 3 hours, often in the bed next to the labor room. But that didn't help patient care because the chance of missing something and missing something dangerous, which would cause a death of a patient or death of a baby, was high. But we don't seem to want to create nursing hospitals, nursing colleges, medical colleges, which are general, not private. Our healthcare infrastructure is poor. So our hospital, and I'll show you pictures of hospitals in the public healthcare. And I think we've all seen pictures of, cattle and dogs and garbage all over health systems. So they're lying on the floor. There are unsanitary toilets. There's a lack of privacy. No bed for the attender. That old lady who's come, the mother or the grandmother who's with her, or the husband who's with her, doesn't have a bed to sleep in. What sort of healthcare are we creating? All this is what I would say is structural violence. In the OPD, there's no place to sit. They're squatting on the ground outside, whether it's sunny or raining or cold. There are no OPD toilets, so women have to walk so many miles to come to a hospital, and then there's no place for her to sit. There's no OPD for the toilet for her to go to the toilet because they're all of only the wards. So where does she go? And she has a bladder full. All of you who know in pregnancy, we need to keep going running to the bathroom so often. So there's no training in medical and nursing care, no sensitivity in a woman in labor. And I think that's one of the biggest things that's happening, that we don't seem to be caring for women. And finally, when we look at all these things which come up, we look at the fact that the training that we have is inadequate. So it's a structural issue. Is it a gender issue now? What do we mean by that? Is it a gender issue? So patriarchy, the needs of the men and the family and society over the needs of women. So a woman saying, I want to go to a hospital, and the family saying, there's no need. Why do you need to go? And the family wants more children, wants the children to come in, wants the children to be born, and how much women are disrespected if they don't have a child. So a woman's responsibility to have children, to give birth, and to produce the right gender. How many times you've scolded a woman who comes with a fifth pregnancy saying, what's wrong with you? And she has 4 daughters. But is she the one who wanted to have 5 children? She would have been happy with 1 or 2 children. But it was a society which was saying you need to have it. So can you imagine her entire tension throughout her 9 months and throughout labor, the anxiety she's going through? Will I have a son this time? Will it be a daughter again? Will I be beaten for this? And we just disrespect her because we just shout at her saying, don't you have the sense not to have 5 children? Not even realizing the pressure she's on, because patriarchy seems to hide that. Patriarchy is the hidden pressure that women have. And finally, from the side of both families and communities, as well as doctors, nurses, childbirth is a physiological process. Absolutely. I totally agree. It's a physiological process. But then why do so many women die during pregnancy and labor and the postpartum? That's not physiological. Why are women living with disability forced to have a child? She can only get married if she can have a child. And if she doesn't want to have a child, that's not even accepted. Why are women forced to have a child when they don't want to have a child, when they're not ready for it? The teenage pregnancy, a woman at 42, 43, 44, because a family says, we don't believe in family planning. We don't think it's good because religion decides you shouldn't use family planning. So it is. So obstetrical violence, forced to have a baby and deliver when you're not ready for it physically or emotionally, is a gender issue. So let's look at the specific things at WHO. So if you look at it, that we have a structural issue where obstetric violence survives, flowers. It's a gender issue. And it's an issue of human rights violations. So in each of these, what are the violations that are occurring? Let's look at physical abuse. Being hit by healthcare providers, being pinched or pushed or shaken during labor pains, as if it's their fault that they're getting pain. And a woman thrashing in pain is considered to be misbehaving. Whereas if a man has a kidney problem or a renal stone, we don't consider it. How often have we said things like, oh, labor pains are the worst pains a person can suffer? And yet, we don't acknowledge the woman going through that pain. So many women have said, forcefully spreading the thighs apart, forcing the knees onto the abdomen, when she could be squatting and delivering. So much more physiological. And then they end up with so many things like iliac sprain, inability to walk. They have so many discomforts and pain and morbidities. We don't even look at the morbidities that arise. As I said, giving an episiotomy when unrequired, giving an episiotomy or suturing without anesthesia. These are all physical abuse. Emotional abuse. What is the emotional abuse a woman goes through? disrespecting the pain she feels. So there is a physical aspect and the emotional aspect. And like my senior had said, it was just being alone with the pain. So a person has kidney stones, somebody has migraines, and all say, oh, she suffers from migraines. She needs to lie down for 2 days. She can't look out. She can't do anything. She can't work in the kitchen. A person has an injury, they fractured their hip or they fractured their foot, and we're like, take care, look after yourself, take something for it, don't come to work. But labor pains? Oh, it's a physiological process. It's something women have to go through. Why? Taunting her for having had sex, knowing that it embarrasses her, the fact that our sexuality education is so nascent, so, primitive, and the fact that pregnancy is a sign that you have had sex, and people taunting a woman for having had sex, where I would say a lot of the time the woman even hadn't wanted to have sex, it was forced upon her. And knowing that it embarrasses her and makes her feel small, that when she's crying in pain for labor, you are taunting her or troubling her for having had sex. Not informing of ways to reduce pain. Can you move? Would you like to have a hot water bag? Would you like somebody to massage your back? Would you just check that your bladder is empty? Would you like something soothing to drink? No, not even considered. Emotionally abusive is leaving a person alone in the antenatal room or the labor room to suffer her pain on her own without anyone next to her. Refusing a birth companion of her choice. No, your mother can come in, your husband can't come in. Why? One of my friends, she was my patient, she went to Chennai for her deliveries in her 8th month. And she asked the doctor when they went for their first checkup with the doctor over there, she said, so my husband will be coming in. Is he allowed in the labor room? And the doctor said, why? And so she said, I would like him there. So the doctor said, no, there's no need for him. So she said, no, I would like him there. I believe it'll be help me reduce the pain, and I would feel very supported if he's there. And the doctor turned around and asked her, but won't you feel embarrassed? And my friend and her husband were looking at the doctor thinking, what on earth are you talking about? Because the doctor was embarrassed to have the husband there. It wasn't the patient at all. So anyway, they managed to convince the doctor, and the husband was there. And it was a great blessing because we'd had birth classes, birth preparedness classes. So he was able to massage her back and help her walk and go to the bathroom and come back. And she had a normal delivery. So here it's about, oh, your mother can come in or your sister can come in, but your husband cannot or your partner cannot. And these are things which are a concern. So refusing to allow the husband or partner to be by her side. Let us look at the institutional abuse, right? Mocking or scolding a woman for having many children. Mocking or scolding a woman for inadequate birth spacing. Haven't you said that before to women? She's come and she says, my first child is 1.5. And you're like, what do you mean 1.5 years old? Don't you know that she should have waited for 3 years? But nobody told her that before she got pregnant. Oh, you've come with your 3rd child, 4th child, 5th child. Don't you have any sense? That is abuse. Mocking her for wanting a child of the required gender. I have 2 sons, doctor. My husband really wants a daughter. I have 2 daughters, 3 daughters. My husband's very keen. My family is very keen. They want a male child. Is that acceptable? How do we allow that to happen? That we are cursing the woman for something that society is harming her for? Forcing contraceptives on her during labor. We use the time of labor saying, after this, you're going to put it easy. This PP-IUCD business is horrifying. That as soon as she delivers, we put an IUCD, and in the pain and trauma, she just agrees to it. It's not informed consent at any stretch of the imagination. That you just put in an IUCD into a woman in her just delivered uterus. I have lots of women coming to me where the copper-T has gone and got into the uterus, got tucked in somewhere because it was put into a uterus which has just delivered a woman. Refusing to allow her an attender is the institutional abuse, where the rule is, oh, no, we don't allow attenders into the labor room. Why? Because there are a lot of women in the labor room and they may feel embarrassed. Have you heard of curtains? Discharging a patient within 24 hours of labor. And so many people say things like, oh, no, because the family wants her to go back. No, it's not that. You don't have food arrangements. You don't have comfortable space for the attenders. You don't have a clean bathroom. A woman has to go so many times to the bathroom. She keeps bleeding. She needs to change her pad, wash her clothes. You don't have water. Of course, she wants to go home, but it's not safe for her. So you don't have these facilities in the hospital of food and water and sanitary toilets. And then you wonder why the woman goes home early. And so many of our rural deaths are postpartum deaths because they've gone home early. This is a labor room and an entrance to the toilet in a rural hospital. You can see what sort of a place it is. This is another sub-center where deliveries take place, and that's the state of the roof. The A&M told me that she holds an umbrella during the rains because there's water leakage during the rains for the woman in labor. But don't let's just think that it's only in rural delivery centers that it occurs. Even in private hospitals, which are so fancy, and they look so beautiful, and they look like, a deluxe hotel room, there is still obstetrical violence because a woman is not listened to. It's just that the fancy markings are there. So looking at these, does anyone have any questions so far? We'll have stop for a second for any questions, if anyone has.
It's been absolutely eye-opening and mind-blowing. I mean, thank you for all the things you've said today. I've just been like on the verge of tears.
Dr. Geeta, do you have a question?
No, just wanted to express what I felt during the lecture. Congratulations, madam. It was an eye-opening lecture. I repeatedly feel the need to sensitize the medicos and the students about these aspects during their career, which we lack in our education system. And I always felt a need that we should have a separate book on childbirth for MBBS graduates, because whatever we read, we always feel that childbirth is a medical process, and we always see and teach them as a disease process. So humanizing the childbirth experience needs sensitizing these medical students. That's a much required step during our career making. Thank you so much for the lecture.
To know that it's very important for us to understand that well, some of you have saying no, and I'm happy to hear that. Many of you have also said yes, that you have seen it. And I think Dr. Geeta, I think was it, who mentioned this, and I'm really happy that you mentioned it, because we have also seen this happening, because a lot of it is Western medicine. And if you know, Western medicine was run by Caucasian males. And if you look at SIMS and the whole concept of, repeatedly operating on fistulas on women without anesthesia, even in France and in the UK, when they tried to apply forceps and things like that, the terrifying things that they seem to have done to women, because it was just the whole patriarchal notion that these are things women go through, and some of them die. And the entire attitude, our textbooks, unfortunately, I think not very long ago, I remember reading that 7 out of 8 gynecologists are male. So if a person who has never gone through labor pains, or even, I think, being a person with a uterus, it's very difficult for them to really understand. So they write in a medical knowledge in cold statistical terms and scientific terms, and they completely forget the human being over there. So I'll just continue. What are the solutions we have? I'm sorry if I've depressed you a lot. Let us look at what are the solutions. Women's empowerment is one of the things which is there. So that is, I think, the ultimate way that I can go through. The first is education. Education is probably the way for a woman to be able to stand up for herself, to be able to say, no, you can't do this to me. You cannot do that to me. Financial security. Financial security helps, not just whether it's public or private. I don't think, as 2 or 3 of you have mentioned, that you've seen obstetric violence even in our private hospitals. Financial security actually means your ability to ask for care. It gives you a sense of strength. There is the power paradigm, power imbalance between you and the doctor or nurse or health provider reduces. Both education and financial security for women improves their household decision-making powers. How many women have been told there's no need to go to hospital for a delivery, or you can deliver here, or we're not going to change the doctor. You can't change the doctor because you didn't like her face or you didn't like her attitude. These are things which are often told to women. So their decision-making power in the family. Or a woman who says, I want to go home to my mother's house for delivery. And you're like, why? And so I must tell you about this occasion where this woman was having severe nausea in her second month of pregnancy, and she was very, vomiting a lot. And so I said, "What are you planning to do?" She said, "I can't get into the kitchen. I can't do anything." So her husband said, "My mother's coming to stay with us and she will take care of us." And the woman was saying, "I'd actually like to go back home." And of course, everybody had told her, "Don't travel for the first 3 months." So when this happened, I asked the husband, I said, "I understand your mother does care for her a lot. She cares that she eats well, gets the food she likes, she'll take over running the house. But tell me something as a man. Suppose you were unwell, you're just recovering from typhoid, and you're very sick, and you're recovering, and you want somebody to take care of you, right? Who would you like? Your wife's mother or your own mother?" And the man said, "My mother." I said, "Why? Your wife's mother will take care of you. She'll cook you whatever you want and she will look after you." He said, "It's not the same thing." I said, "Really? Why?" He said, "Because with my mother, I can make a fuss. I can say, make me khichdi and then turn around and say, I don't want to have that. Make me something else. With my mother, I can ask and not have to worry about whether she'll still love me after that." And I said, "Exactly. That's what your wife's saying. Your mother will take care of her. But right now, she wants a mother." And it was so sweet of that husband because he immediately bought a ticket for his wife and went to drop her home to her mother's place. And she came back after 3 months, happy and relaxed. So these are ways that we also have to educate men about what a woman's going through. Then freedom of movement. This is what I meant, that she can go home, she can travel, she can go to work or not go to work. She can decide to work from home. All these things are important, that there are not what we call in Hindi pabandi, the chains of the family deciding where she goes and doesn't go. Health literacy. Health literacy is important because for women to understand what's happening to their bodies, not in a medical sense alone, but in a sense of physiology, of really understanding how important it is to be able to make right choices about where you want to deliver, whom you want to deliver, and that you have the choice. And also to understand what are the danger signs. I would even say legal literacy, because sometimes you can tell a nurse or a doctor or a hospital, you can't do that. It's against the law. And I think it's important for women to be able to stand up and say that. So these are the various solutions for empowerment. What else do we have? And as Doctor said, gender and medical ethics, teaching and training in this for doctors, nurses, and paramedical staff. The importance of how gender traps you. Medical ethics, which we need in terms of treatment of patients. Training in colleges and schools, and not medical colleges alone. We need to talk in colleges and schools to young men, growing youth, men, women, others, about what are the rights you have, reproductive rights, because that ultimately results in what you can do, whether you want to give birth, don't want to give birth, all these things come in there, all the rights that you have. The national quality standard audits, I'm sure many of you who are medicos or who have worked in hospitals know that we have NQAS, National Quality Assessment Standards in our country. That's hospitals have to have certain standards, rooms, toilets, certain level, you can't put a mattress on the floor, you have to take care of the patients. And we can have audits of these. The patients also need to know, people need to know, the general community needs to know what are the standards that the government requires my hospital to have. A shift in thinking of professors and teachers in medical and nursing colleges. I think we need to move away from the traditional way of thinking and listen to patients much more. Look at what the patients require. The corporatization of birthing. Sometimes my patients come with this long list which they have been given by their hospital saying, these are the things you need. And the first thing they have is milk bottles. They have teething rings. They have things to suck out the mucus from the nose. They have such strange things which are not even needed, but they immediately put the idea into your head. So one of the things which some of my younger junior doctors have been telling me who work in corporate hospitals is that the sales manager tells them, please tell your patient she shouldn't go home for a delivery. Just, please let her know that it's dangerous for her to travel. And her home may not have the hospitals in a home will not have as good a systems as we have, neonatal care, ICU, blood. So she shouldn't go. Let her deliver here itself. I was quite horrified to know that. This pink and blue decorations for babies, this sort of, I don't know what you'd call it, icing on a shit cake. I mean, I keep telling my patients nowadays that your child is a boy or a girl biologically, but when the child will tell you within 2, 3, 4 years exactly what their gender is. Until then, just relax. Use green, pink, green, yellow, white, purple, so many colors. You don't need only pink and blue. Insufficient support for breastfeeding. It's like, oh, baby's crying. Feed the baby, feed the baby. None of us during obstetric violence, I would consider a very huge part when you don't put the baby on the mother's abdomen, when you don't allow the baby to breastfeed or start suckling, to root, to sleep on the mother's chest and get that comfort after a very traumatic journey. We often say that the first journey in our lives can be one of the most traumatic or one of the most beautiful, peaceful ones. Then what else? Birth preparedness classes for the mother and the family. Unfortunately, birth preparedness by the WHO says, which hospital are you going to? Who's the person who's going with you? Do you have money for the travel? And do you have somebody to donate blood? By the end of it, the person's so scared they don't want to go anywhere near the hospital. There's so many other things in birth preparedness. What is pregnancy all about? What will labor be like? What are my options in labor? What all can I ask for? What all can I refuse? Understanding how a birth companion helps, the fact that a birth companion makes such a difference to the general health, to her pain, to her feeling of being secure, to her feeling of not being alone. Understanding care of the newborn. What do I do with this baby which has just arrived? I'm so scared. What do I do? That fear, that anxiety, just reducing it by helping of using dolls during pregnancy, showing them how to hold the doll. Earlier, we didn't need to do this because in joint families, the elder sister was carrying around the younger sibling, or, she had seen her sister having a baby, her sister-in-law. They knew it. Now, as our nuclear families develop and as we move away from the joint family, we don't have the habit of learning it. I remember when my daughter was born, second child, I was feeding her in the room and a friend came to visit me. It was probably about 2 weeks after the birth. And she came to the door and my grandmother opened the door and she said, oh, come. And Shaibya's feeding the baby. She said, oh, then I'll come back later. So she said, why? She says, no, she shouldn't be disturbed while breastfeeding. So my grandmother said, come inside. And she came into the bedroom and my son and his friend were 4 years old, jumping on the bed, playing Ludo because he wanted to be close to me. Another friend was sitting and chatting with me. We had a tray out there with cups of tea and snacks, and the baby was happily feeding away, not even bothered with all this running around in chaos and completely focused on her job, which was to drink milk. And she said, I grew up being told that you should sit in a closed room. Don't let anybody come inside when you're breastfeeding. And I felt so alone. I felt so sad. And I'm looking at this room and it's like, happy time. And it is. It's such a beautiful time. So understanding the postpartum needs and care of a woman to have her feel happy and contented and relaxed and cared for. These are the ways, these are the solutions we all have. And finally, in care and labor, comfortable, airy, clean rooms, asking her to move around in the stages of labor, walk, move, sit near the window, sit in a hot tub, take analgesia, whatever you would like. Have a birth companion of your choice. Insist on it. A squatting or semi-reclining position, don't make them lie down. Why are you forcing them against gravity? No use of stirrups unless indicated where it's really needed. Even for forceps or vacuum or even for episiotomy suturing, you do not need stirrups. A good perineal support rather than episiotomies. If you have to give an episiotomy with anesthesia, if required, otherwise not. Informed consent for everything, particularly any surgical procedures. Talk to her, discuss with her. If for every woman, we all know, as an obstetrician, I know any labor can go south, right? I can suddenly require fetal distress happens. I have 4 loops of cord around the neck and the baby's suddenly dipping down. And it is still too high for me. I need to do a cesarean. But I should have explained this in birth preparedness classes that there is this small chance. It's low. I will try and avoid as far as possible. But if there is, I would like your permission for it. And I will only do it if it's absolutely necessary for you or the baby. And that's the trust the patient comes with. And finally, having a doula or a birth companion. When a doctor tries to be everything, when a nurse tries to be everything, they're not able to. So please try and do that. Take care for everything. Thank you.
Thank you so much. This is amazing. I think we have a saying, cliched saying that, prevention is better than cure. While we are trying to prevent the risks for what we perceive, the risks that the baby has during labor, we are actually, creating more risks and more, more invasive things that we're doing to the mother in the process many a times. I think it was really, really eye-opening. We've all experienced this or seen it in subtle ways or very in-your-face ways, as in our own journeys as being care providers. And I think it's very, very important to know, to be conscious of our power that we hold, right? And to know that we have to be checking ourselves at every step and knowing what to do and not what we should be doing. So we are open for some questions. We do have 10 minutes left. So if anyone wants to ask any questions or type it in the chat box, we'll be happy.
I would love to ask a question, if that's okay. Dr. Shaibya, it's such a pleasure to know you and to learn from you. I'm a newcomer to India the last 3.5 years, and so I've gathered a lot sitting across from parents and hearing their stories. But with your 30 years of experience, I'd love to ask you how it's going when your colleagues find out the tremendous revolution and transformation that you're requiring of them. When they get to work with you, I assume you can bring them into your world. But when they just hear about you, like perhaps someone watching this video after the fact or something, do you get pushback from the other gynaes?
No doctor actually wants to commit obstetric violence. They just don't know that what they're doing is violent. And that's where it's important to have a different face or a different way of doing things. Because if you don't, then where do you know what's right or what's wrong? We were never taught this. We were not taught any of these things. So here and there, a doctor who was my teacher would tell me, this is what works or this is what doesn't work. But most doctors would like to. Because, the patient trusts you, and every doctor would like a patient to trust them. Sometimes doctors are so busy that they don't have that time, and that's when they miss out. And that's where it's important, I would suggest for doctors to do group practice, to have an understanding that all of you can take care, so you don't have to stretch yourself and cause harm.
That's what I was going to say. One of the things that I think contributes to this and that I keep hearing from is these 50 patients a day in labor in the hospital and 100 in the month or something crazy, where the one doctor is just running back and forth and they barely ever sleep. And how could they ever build a relationship or listen or spend any time with them because they're so busy? And certainly India has a lot of births. One solution, like you said, is group practice. Can you think of any other solutions for gynecologists who are ready to make this change?
Well, actually, birth preparedness classes for the doctors and nurses and everybody in the labor room, a sort of sensitivity sessions for everybody in the hospital, understanding what it's about. And for the family, when we do birth preparedness, it's always for the family, for all the people who will be taking care, like the mother-in-law, the mother. I've had so many women saying, because the mother-in-law came in for the breastfeeding classes and talking about weaning foods. So I would say, don't just say, oh, the baby's crying, is the baby hungry? It scares the mother. Just relax her, say, have another glass of milk or drink something. What would you like to eat? Don't pressurize her. Yes,
Yeah.
Dr. Midwifery is the answer. Absolutely.
Yeah, I agree. That was going to be my next question. I know you agree. Dr. Geeta is obviously banging the drum for adding midwifery. The problem is that the experts in high risk and surgery are running around trying to take care of normal, right? And so if we had the right balance, if we had more midwives providing care for normal women, we would reduce everyone's stress level, I think. Yeah.
I think Sharda wants to say something.
Yeah, yes, doctor. So I have a question, like whenever, in fact, I have two children, both of them by normal vaginal delivery, but I had episiotomies both times. What I have question here is, I always keep wondering, in India, why do we do this deliveries in lying down posture? I see in movies and all in other countries, they do in sitting posture or, pushback. Isn't it something very, very important? We are not taking the advantage of gravity and this very important thing. And in a country like India, where it's a huge population, why are we not following this? Doesn't this come up in your gynecological conferences?
It does, because we started now at least getting the beds which can sit up with the feet, pressure for the feet and things like that, with that hole in the center. At least that's changed now. But somehow doctors seem to be very nervous about it. And actually in the villages, if you look at it, the women have a rope across the room and they hold the rope and they squat down and they deliver. Yes. And it's so easy and comfortable for them, and they don't have tears and damage. They don't have pressure. The baby delivers so beautifully. It's really absurd, some way, because our senior doctors are still not able to change the minds and they're not teaching properly. Yeah.
I just like to add in here that, I had a session with traditional birth attendants who have received some training from mainstream OBs in central India, Chhattisgarh. And it was very interesting when, as a midwife, I was interacting with them and I was asking them, what position do women give birth in? They were like, yeah, previously, 20, 30 years back, they were squatting and giving birth. They used to make a seat with a lot of cloth, like make a coil of sorts, and they would sit on that and someone would hold them from behind and there would be the midwife in the front helping them deliver the baby. But then after they had sessions with the doctors, they are now having all the women required to lie down and give birth against gravity. So, we have to preserve our traditional knowledge while bringing in, modern techniques and know-how and evidence-based care and all of those things. I think it should be a balance, as you said previously. Yeah, thank you.
Yeah, for medical equipment manufacturer, we should start suggesting birthing chairs rather than birthing cots. So, I think it's time that we should change our attitude and approach towards childbirth.
Madhvi has a question. She says birth preparation classes that are conducted in hospitals only sensitize women for all the invasive procedures that they are planning to do during labor. How do we change this attitude?
Yeah, because birth preparedness is about talking about what's happening to your body, how it changes, how can you take care of yourself in the most natural way method, how can you keep everything clear. That's very important. So I think that is what corporatization is. Yes, Madhvi, go ahead.
Ma'am, so what I wanted to ask you is all these procedures and all these, the evidence-based care and all that is a midwifery model of care. And we are trying to look for this midwifery model of care in an obstetric model of care. Isn't it confusing? Because what we teach in the childbirth education classes, none of these things get applied in the hospitals. Like, I'm talking about Bangalore and, the corporate hospital culture that we have here. So ultimately what is happening is women are confused, or women are totally, sometimes they feel they are cheated or they are, abused. Because, what is midwifery model of care we are teaching? We do not have enough centers or enough people to offer this kind of service. So I don't know, I'm confused. If I have to tell, episiotomy is not a standard procedure, but then 99% of the women go through it in Bangalore, ma'am. So what is it? How to deal with it?
So I would suggest birth preparedness classes for the doctors and nurses, actually.
Yeah, ma'am. But then the OBs and the nursing staff, there is a lot of ego issue, ma'am. They don't even encourage women to attend classes because we teach all this and then the women go back. I had experience with a lot of OBs, these women who go with the birth plan. I mean, the birth plan is thrown on their face, and they are being, asked to get out of the room and do not come back if you don't trust me. All these kind of things happen, ma'am. So,
Tavi, my suggestion would be that you come work with us and we'll help you open a facility of your own. This is the only solution that's going to change, is that basically we answer the call by opening more and more facilities.
But
Training
also
more midwives.
sometimes I don't think it's bad for us having a lot of doctors and patients getting aware, because the more and more patients who start demanding this care, like, will you give an episiotomy? I would rather not have an episiotomy. If you're doing a cesarean, I would like to know why. What are the issues? I want to breastfeed. I don't want the baby given formula. And I've done that with patients, and they've insisted on it when they've gone back to their hometowns for delivery. They've told them, no, I know there's no milk, it'll come. No formula for the baby. And they're like, no, your baby will starve. And they keep calling me and said, nothing will happen. Don't worry. And they manage. So you're empowering women. And it will take time. It'll take time, but it's
and
good.
neonatologists, they don't want the baby to lose any weight, even if it is in the well-informed weight, well-limited weight loss. They don't want the baby to lose weight at whatever cost it may be, and they are okay to give formula male time.
They don't understand.
Neonatologists are the biggest threat for breastfeeding, ma'am.
I know, it's so crazy. The fact that it's normal for every baby to lose 10%, even if it goes to 12%, but the baby's peeing okay, potting okay, the green is turning, black meconium is turning to green, which is turning to yellow. It means the baby's doing fine. A baby who's sleeping on the mother's breast and totally happy and comfortable, even if they've lost 10% of the weight, is a very healthy, happy baby. And now that we're talking about microbiomes, the importance of developing the microbiome in the baby is so essential. And that only comes with breastfeeding and licking the mother's skin and her nipple and getting all that lovely bacteria inside to colonize their nose and mouth and intestines. It's so essential for the parents and doctors to understand.
I think that the change has to be multi-pronged, right? Like, definitely have more midwives, have more conscious providers, change the systems, as you talked about, the education systems and the way we, think about offering care. And it has to be a multi-pronged approach. And even if, when as childbirth educators, many of us here are childbirth educators, when we are talking about birth preparedness, and women can recognize that they're not getting what is due to them, what is right for them, I think that itself can make a difference, because they're going to tell their friends or their cousins or sisters or whoever else is giving birth that, this is what happened to me and it shouldn't happen to you. So let's change this, right? So people are getting more and more aware. And I think we should, collectively have a movement towards changing it, one baby at a time, one mother at a time, one care provider at a time. And as many of us have expressed, I think midwifery and following midwifery model of care in the hospital setting, and what Augustine said, that midwives are the experts in normal, and we do need obstetricians. The few surgeries that I have witnessed over the last year, the C-sections that I've witnessed last year, they're amazing at doing such a good job of it, and it is a life-saving surgery, right? So we need everybody, but we need everybody to work together so that we can, provide the kind of care that our mothers and babies and anyone who is wanting to birth deserve. Yeah. All right. So I think if anyone has any more last things to say, please chime in. But I would really like to thank you again from the bottom of my heart. And I hope to see you in person very soon.
So thank you so much for inviting me. And I'm so delighted to have talked to all of you.
Yes,
and please feel free to contact me or work with me in any way that you would like further. All right. Thank you so much.
Thank you so much, Dr. Shaibya.